Welcome and thank you for tuning into Derm Docs powered by LiveDerm. This is the second of a 4-part educational series. This episode, entitled Topical Steroid Withdrawal, Myths versus Science, features board-certified dermatologists, Dr. Mona Shahriari and Dr. Peter Lio.
My name is Mona Shahriari. I'm an Associate Professor of Dermatology at Yale University and the Associate Director of Clinical Trials at CCD Research in Connecticut. And I am joined by my good friend and colleague, Dr. Peter Lio. Peter, why don't you introduce yourself?
Thank you so much for having me. I'm Peter Lio. I'm a Clinical Assistant Professor of Dermatology and Pediatrics at Northwestern University Feinberg School of Medicine in Chicago, Illinois.
Well, thank you so much for being here, because in this episode, we're actually going to be separating fact from fiction and debunking myths when it comes to the concept of topical steroid withdrawal. And I know that you are quite the expert in this arena. You have a lot of passion on the podium when you talk about it. But I think we can both agree that when the topical steroids launched in the 1950s, we felt that they were one of the best things since sliced bread. We were using them anywhere and everywhere because of those broad immunosuppressive effects that worked in a lot of the dermatologic conditions that we treat. They were easy to access. I even remember telling patients that, well, we don't need to know if it's eczema or psoriasis because this topical steroid can treat both. But with all that power comes great responsibility. And so in your opinion, what do you think some of the challenges are that come from either overuse or misuse of our trusted topical steroids?
No, I absolutely love that. And it's true. They were transformative to both our specialty and to all of medicine. They, for the first time, really empowered us to treat a lot of things. They're so powerful that there's an entire category of diseases called steroid responsive dermatoses, right? They literally are definitional drugs. And I would never speak ill about them in broadly. Like, they're still so important. As you say, they're accessible, they're reliable, they really help people. That being said, when we have something that's so powerful and so transformative, it's easy to get lazy. You can start saying, well, I'm not really sure what this is. Let's just throw the steroid at it. And of course, we know that, especially having had these since the 1950s, we know there are a lot of side effects that are potentially able to develop, especially over time. It really seems to be that more chronic use where we see all these issues. And if we're not good stewards, we end up in some troublesome waters, right? And we see this over and over with other medicines too, where we get too reliant, we kind of let our guard down and the stewardship falls. We see this with antibiotics as well. So I think that's that tension, that wire we have to walk, where we can use them, but we have to be careful and be good stewards and do it safely. And if we don't, then we can really start seeing some of these effects that we do not want.
Exactly. So just to help our listeners understand, what are some of those unwanted effects, whether systemic or cutaneous, that you're alluding to?
So I think we know, if we read like the guideline documents, like the ones that are absolutely not controversial at all, everybody agrees that if you keep putting steroid on the same area, you can start to thin the skin. And if we do this too far, we can actually get stria. We actually get permanent stretch marks. And I was involved as a resident. I remember there was a case at the VA hospital. A patient was trying to do a malpractice suit. Apparently, when you sue at the VA, you sue the federal government as well. Like, it's a whole thing. Wow. And it was because his primary care physician had recommended using a combination steroid and antifungal for the groin. It probably was inverse psoriasis. And he had been doing that for years, a high potency steroid, and had just unbelievable stria all through his groin. The skin was, falling apart. He was getting cuts and fissures, and it was really bad. All his scrotum as well. And nobody told him to stop. So that's like one of those, I think, slam dunk kind of situations where it's like, this is clearly bad. But then we know there are kids, especially kids, who can absorb a lot of steroids too. So maybe they're only using a mid potency, but especially a baby, their surface area to volume ratio is quite different than an older patient or an adult. And they can absorb a lot and start getting systemic effects, everything from increased blood sugars to, of course, some of the issues with growth, falling off a growth curve. We look at this and you can see these kids who are using a lot of topical steroids, they start to fall off. Now, often they will catch up, but in theory, you could actually prevent them. Of course, we're also suppressing our immune system broadly, so the potential for infection. And when you look at some of the things like cardiovascular disease risk factors, all these things like systemic corticosteroids can do, our bone development. So it keeps going on and on and on. Many issues with systemic steroids that, of course, are even more serious than topical ones, but can be mimicked or reflected if we're using a lot of topical steroids that are getting absorbed.
Of course. And I think I see a lot of skin of color in my practice, and the pigmentary changes are also another adverse event that my patients complain about. And oftentimes they tell me, you're not going to give me another steroid, are you? So I think they have that fear. But I know nowadays we're becoming a little bit more aware of the concept of topical steroid withdrawal from just that overuse. So just so that our listeners are aware, can you tell us a little bit about that? And is it as scary as it sounds on social media? And what is it really?
So the story of it is kind of fascinating. And I wanted to just tell one other story about the beginning of steroids. One of my teachers who passed away a few years ago, Sam Michella, rest in peace. He was an amazing teacher. He practiced before steroids were in wide use. So I remember we were at a grand rounds and he was telling us the story. In the early 1950s, he was practicing. We were like, Dr. Michella, what did you guys do? And he's like, a lot of petrolatum. They didn't have anything. So steroids were transformative in his career. And again, I don't want to say that I'm anti-steroid. I'm not. And I have to kind of state that because sometimes people get very militant and push back and say, you're just trying to get rid of steroids, or, you're trying to sell expensive non-steroidal agents. We're not. I mean, like, I still use them every day. I probably use more steroids than most because my whole clinic is focused on eczema patients, right? So I don't even see acne and stuff to take me away from the using steroids. But that being said, the TSW was originally described pretty early on. There were some papers actually late 1950s and early 60s. They often had different names where they would call it. Some of them were called red skin syndrome. Some of them, they were just kind of describing more of a rosacea, like a steroid-induced rosacea. And we know this papulopustular variant is a real thing. It's kind of different than I think what the modern movement is all about, but that's real. And I've had patients, I'm sure we all have people who are putting steroid on their face and got a terrible rosacea-like or periorificial dermatitis. Little kids, they often can't use a steroid inhaler for asthma. They'll use a mask, right? And you'll see terrible, terrible periorificial dermatitis. And you're like, are you using a steroid inhaler? Yes. Can we try to switch them to one that goes in the mouth? Yes, they're big enough now. Let's try it. And it just disappears. So these are things we've known about for a long time. But yeah, the most severe stuff I think really is in the last couple of decades where we've seen these reports of people that were using a lot of steroid. And what I find, and this is controversial, I want to be clear, because this is sort of my take on it, but you often find these people using escalating amounts. They need something stronger. They need more of it. They're going from hydrocortisone to triamcinolone to mometasone. Now they're using clobetasol or betamethasone. They're pouring it on. Then what they're finding is it's not helping as much. And when they stop, it goes crazy. It gets super red. It gets super reactive. It's flushing, blushing, sensitive skin. And it's now even going to areas where they maybe didn't even put steroids on in the first place, or where they didn't have underlying disease in the first place. And now the patients I'm seeing are super severe. To me, they're essentially indistinguishable from severe erythrodermic atopic dermatitis.
And so that actually brings up a really important point, because sometimes when you talk to clinicians, they say, well, is it truly topical steroid withdrawal, or is this just a severe form of AD, erythrodermic type? So the million-dollar question is, how do we spot it and make sure that we're not missing it in clinical practice?
100%. And I think that is the big question. And I will tell you, kind of spoiler alert, we have a paper right now. We've been working on it for I'm not kidding you, several years. It's been back and forth and back and forth with the whole group of us who are trying to develop some diagnostic criteria. And the sticking point really has been, and again, I hope someone smarter than me will figure this out, but we've not been able to really come to a satisfactory conclusion that essentially at the end of the day, it may be impossible to distinguish reliably with clinical tools alone, barring maybe some really cool breakthroughs with a biomarker or some kind of endotype that we can find. But with clinical tools, it may be indistinguishable from severe refractory erythrodermic atopic dermatitis. That being said, to me, it kind of doesn't matter. So if I meet a clinician who's like, oh, I think it's a bunch of baloney, I can just say, no problem. This is clearly a patient, though, who's sick, who needs help, right? And who's way abused steroids and really probably shouldn't be on steroids, because you've seen what's happened when they've gotten multiple courses of prednisone or used tons of topical steroids. Like, clearly, we should stop doing this, right? And I think most clinicians who are willing to work with their patients at that point say, yes, I agree. We got to switch things up here. The more steroids is definitely not the answer for this patient. So at the end of the day, I'm happy either way. If you sort of quote unquote don't believe it, but still treat it appropriately, I'm all in. You can call it whatever you like. My concern though is when we'll have patients come and see me and say, my last doctor kept saying, no, quit being difficult. All you need is more triamcinolone, and giving them more steroids, even though the patient clearly is doing terribly with this. Like, they're not only are they not improving, they're actually getting worse. So this is that delicate balance. But I can tell you a couple of things we're looking for. The first and foremost really, I think, is listening to your patient, right? The patient's telling us that steroids seem to be making it worse and their rebound is way worse than we'd expect. Because I've also had clinicians push back and they say, well, of course, if you have severe eczema and you put topical steroids on, if you stop abruptly, what do you think is going to happen? It's a chronic disease. Of course, it's going to come back. And of course, you might have some rebound. Are you crazy? It's like, no. I hear you. I believe you. And I trust me, I've seen this. I know. I totally know this. But these are patients who do that. And then instead of just a week or two of being flared up, right, we're talking this is going on for months and years, and they're miserable and they can't seem to recover from this. So this is not a physiologic kind of a rebound thing if you believe in such a thing. This is not not tachyphylaxis where suddenly the steroids aren't doing as much, because it's actually going to new places and it's manifesting differently. So this is, again, these are different. They're all close concepts, and you have to be kind of paying close attention, because I agree, you can dismiss it and say, oh, it's just this, but it seems to be its own thing. And the last piece I'll say, and I'll shut up for a minute, but it's just that when this all started, I was skeptical too. The original group, which is still around today, actually quite powerful and wonderful as a patient support group, it's called ITSAN. It used to stand for International Topical Steroid Addiction Network, and now it stands for Topical Steroid Awareness Network, which I think is better. It's a little bit less militant, but the first was kind of angry. And I thought, boy, maybe this is not real. Maybe this is just patients who are upset and angry that they have a chronic condition. And I didn't really believe it initially either. And then I started meeting some of the patients, and I'm like, okay, like I've seen a lot of atopic dermatitis, right? This doesn't really fit into my definition, even though I agree it's slippery at the extreme. But then what it started making me do is look back and say, some of these super extreme patients I saw before, maybe they were actually TSW and not atopic dermatitis in the first place.
Well, and I loved all the pearls you gave us, because it's not a cookie cutter definition. And I think when it comes to treating AD in general, it's heterogeneous. We know that the disease can look differently. But if I took a couple of pearls away from that, is that if you realize that the disease is not responding the way that you think it would, you give them a topical corticosteroid and the patient has massive rebound when they come off of it, think of topical corticosteroid withdrawal in the back of your head, and then maybe reconsider your treatment algorithm. But I'm sure there's people who are listening in and they say, well, how do I manage my AD patients without my trusted topical corticosteroids? And you mentioned Dr. Michelle, who had lived in an era where there weren't topical corticosteroids available. But since you treat a ton of AD kids and adults, what does that algorithm look like for you? And how can we avoid topical corticosteroids being the only line that we go to?
Oh, I love it. So thank you. So that is exactly why I wrote just a year or and a half ago, a paper talking about a therapeutic ladder for atopic dermatitis, completely sans corticosteroids. So we built this paper up. It actually was published in the journal Dermatitis. And I was quite happy that it got through. I wasn't sure, because it's kind of more of my opinion on stuff, but it kind of made it through peer review. And you'll see it's a ladder talking about all the wonderful options we have that are non-steroidal now. So this is the best time ever in the history of atopic dermatitis to actually avoid steroids. You know, a few years ago, it's like, I agree with you. It's like, what are we going to do? Cyclosporin for everybody? It's off label. It has its own set of dangers. Phototherapy is not a great fit for everybody. But now we have all these things. So looking at the landscape of AD, and it just keeps getting better, right? Of course, we have our non-steroidal agents. In 2000, we got tacrolimus. 2001, pimecrolimus, right? Those are still around and they're generic. Then long drought until 2016, we got crisaborole, right? Bore for the boron element for the PDE4 pathway. Now we have another PDE4 blocker, right? And that's topical roflumilast. We have topical ruxolitinib. We have topical tapinarof. So we have so many things. And then, of course, we have our 4 biologics for 12 and up: dupilumab, tralokinumab, lebrikizumab, nemolizumab, 2 oral agents that are JAK inhibitors with upadacitinib and abrocitinib. It's unbelievable. So, and we have a pipeline that's incredible. So we can definitely get around it for so many people. Plus, you know, my other kind of interest is integrative and alternative medicines. We have lots of great moisturizers. We have botanicals. We have supplements. We have so many things we can do for so many patients. And I find that I don't need steroids the same way I used to. That doesn't mean I don't use them, like I say, and it doesn't mean I'm against them. But for the patient who says I'm steroid phobic, which is a real thing, and I agree, it can be a problem. But especially for the patient who I think has TSW, we can work around it.
Yeah, no, I think those are all the important points that we want our listeners to take away. And I guess the question I have is, I've diagnosed topical steroid withdrawal, and I don't want to use topical steroids in particular. If someone has moderate to severe AD, or even mild to moderate AD, or they're not ready to go on to a systemic, how do you choose between the different topicals that we have in the space? And what does that algorithm look like for you?
Yes, I think there's a lot of art to this part of it. You know, I think finding what the patient likes is really important. But my basic structure in approaching this condition, and I feel like this helps so many patients, is to write out an eczema action plan. And my plan is biphasic. So I have when you're flaring up, okay? So, and I put when you're red, scaly, itchy, crusty, oozy, okay? You're going to do this more intensive plan for a few days. I write it for up to a week. Some people, colleagues that I trust, will say even 2 weeks, but I like to keep it even briefer. I feel like if you're doing it right, within within a few days, you should be better. By a week, you should be basically clear. Then once you're better, you switch to the maintenance plan. And the typical structure will be when you're flaring up, I have my steroid. I love mometasone. Mometasone is kind of one of my favorites. It has a good wallop, but it's pretty safe. I usually pick it in an ointment base. I mean, obviously it's not for everybody, but it's one of my go-tos. So I'll have mometasone in the morning, mometasone at night. I also love wet wrap therapy. It's so powerful. They can put a damp garment over an area if the hands are bad or if the wrists or ankles. So powerful. It intensifies it. It cools it. It helps protect it from scratching because, right, it actually is a physical cover too. I love all those pieces. So I might say do that for a few nights or up to a week. Now you're using your steroid, right? You're doing it. So I'm not steroid phobic, okay? But you're not going to keep doing it. Once you're better, now we shift to that other plan. Now here, we're going to use one of our beautiful non-steroidals. What's my probably basic go-to? Tacrolimus is great. It's inexpensive for most people because it's generic. It still packs a wallop. It's great. It's pretty safe. Now, my other new favorite, I have to say, is topical roflumilast. It's once daily. It's a very lightweight cream base. It's very well tolerated. It's milder in my experience, but it can be great as a maintenance therapy. It doesn't have any limitation. Of course, I also love topical ruxolitinib, but that has a little bit more warnings and a box warning, but a little more powerful too. So you can play with this and talk to the patient. But a great combo for me, for a lot of my patients, if you could just cheat and look through my notes, what do I actually say at the end of the day? It's like, okay, mometasone twice daily plus wet wraps when they're flaring. Once they're better, gentle moisturization, gentle bathing, avoiding your triggers, all that stuff, and then topical roflumilast daily to the trouble spots. And that combination is magic. Now, if that's not enough, we might then say, okay, you're ready for a systemic. What's my first systemic? Phototherapy. I love phototherapy, right? People say, oh, he speaks for all the companies. I do. I'm interested in all sorts of therapies, but nobody makes real money with phototherapy. Even me, I think we lose money on the down phototherapy unit, but who cares? It's great. The patients love it, but a lot of patients can't do it. So then usually we'll shift to a biologic. And again, we have 4. And if that's not enough, then I'll often use a JAK inhibitor. And if that doesn't work or is not enough, or there's a contraindication, we can still fall back to methotrexate, cyclosporin, azathioprine. All those are things I still, unfortunately, have to use sometimes, and they can also help.
Yeah, and on the topical route, when you were talking about just the flare regimen versus the maintenance regimen, there are going to be some patients that might say, you know what, I'm not that bad. Doing this dual regimen seems a little confusing, a little bit complex. Is there any way to simplify it further? So are there individuals where you would consider going to that non-steroidal off the bat? And what kind of scenarios are those?
Absolutely. And I do feel like, for example, topical ruxolitinib, our topical JAK inhibitor, is powerful. And there was a neat study where there was a comparative arm against triamcinolone, and you can't make a superiority claim from that study, but numerically it was more effective than triamcinolone. So I think if you had to pick one non-steroidal to really do the work of a steroid, I feel like Rux can do it. It can carry its weight. And then you could just say, use that when you need it. I feel pretty good. Now, technically that's indicated for non-continuous use, so we could use it for maybe 8 weeks or so and then take a little break, but that's all most people need. And the other issue with that is sometimes we're seeing insurance companies push back if we're doing that plus a biologic. You'll see this kind of, right?
I think you and I have a paper coming out on the safety of that combination, but insurance companies, I don't know if it's the label, they just don't want to pay, but I definitely agree with you there. I do love our 2 topicals, tapinarof and roflumilast, from their once a day dosing regimen. And I've had some patients who, if they're willing to wait, like give it that time, the 4 weeks or so, to see some sort of an effect, it is a great option for the long term. Obviously, if you're in a flare situation, that is not what you want to start with. But for patients who are pretty stable with their AD, I think it's a nice option. But to your point earlier, combining with systemics, these topicals do not have any language in their label that you cannot combine it with an oral. You cannot combine it with a biologic. And what I tell my patients is I can't get you 100% clear 100% of the time. So use these as touch-up paint for that little bit that kind of breaks through. And that gives them that peace of mind of, you know what, I'm not going to have a massive flare because I will have the ability to keep that in check. And I know we talked a lot about our topical corticosteroids being the be-all and end-all with respect to topical steroid withdrawal. But I know some people might be thinking that, well, I'm never going to prescribe a topical steroid again. Maybe I should just shift my entire practice to these non-steroidals because of all the virtues you guys talked about. And I don't think that's really the point we're trying to get across. You had mentioned this, that we both like our steroids and we use them appropriately. It's about using them responsibly, minimizing the risks and maximizing the benefits. So in what scenarios do you feel like the topical corticosteroids are being used appropriately in your clinical practice? And is there a time frame where you're like, all right, after this time point, you do need to stop because I'm worried about bad things happening?
My rule of thumb, and again, it is just a rule of thumb, and I wish we had more data on this to help back this up, but it seems like if you can say within a given month, about half time should be steroids or less. If you're half time or more, then I'm concerned, right? So to any given area, if you say, I kind of needed it 4 days the first week of the month, then I needed it the whole second week of the month, then I needed it a few days, it's like, that's too much. Whereas if you say I used it a couple days the first week, then I didn't use it the second week, then it's like, you're fine. So I try to have them tally it up, and I'll use tools like Eczema Wise, which is the free app from the National Eczema Association, the patient support group and advocacy group, that they can track their usage. So that's important, I think. But part of it is also looking at the patient. So one of the hardest parts is people come in and they have 60% or 70% body surface area, and they have a 80-gram tube of something, and you're like, this is probably not going to be possible. So there are situations where I think you kind of have to jump up to systemic, even for a while. Maybe it's not forever. I'm a big proponent of being able to take breaks from these things. When I give somebody a dupilumab or a biologic, I'm often saying this is not forever. We're going to do this for some period of time, maybe 6 months, a year, maybe 2 years. But if you're doing great, I do want to potentially take you off. And I wrote a paper a couple of years ago showing the potential remittive effect that many of the patients who had to come off for varying reasons, this is before I was playing with it, but people said, I'm going to be traveling, or I'm going to try to get pregnant. They came off. I tracked them. And for many, many months, all the patients that I tracked stayed better than they were before the drug. So I think there is the potential for remission, and that's important too, because I think that can make patients who are very anxious about going on a biologic or an oral medicine, they can make them feel a little bit better that this is not like diabetes. We're not replacing something that's lost. We are trying to control a disease that is very cycle-based, right? And you're in a revved up cycle, a vicious cycle. We're going to break that cycle. We're going to get you a virtuous cycle. Your sleep is going to be better. We already have data. Microbiome improves with both dupilumab and tralokinumab have shown microbiome improvement over time. This is fabulous. We're going to break some of the behavioral aspects, and then it is very likely that you're going to be able to at least take down some of the intensity of your prescription medicines and your systemics. And we already know, like, all the new biologics have a dosing schedule after a certain period of time that is literally 50%, right? For Tralo and Lebri, you go to monthly dosing. For nemolizumab, you go to every 8-week dosing when you're better. So to me, that is already a relative remission.
Well, and I think that is the wave of the future and the dream, that if you take a drug away, can you make it such that not only does the patient not have the disease come back for an extended period of time, or maybe they don't have it come back ever. Maybe they don't have the other aspects of the atopic march come out. So I know we have a lot of drugs also in development that are looking at that, but I think as an AD specialist, that's something that we strive for in everyday clinical practice. Now, one other question I have is, because when you think of non-steroidals, I'm sure there's people listening who say, you know what, my history with these has been that they're not very well tolerated. They're not very strong or effective. That's why I prefer to go to my topical corticosteroids. I won't even get into the access discussion, because we know that's going to be different from state to state and payer to payer. But what would you say to those skeptics about these non-steroidals?
I would agree. First of all, I would agree, right? I think you're correct that topical steroids are essentially impossible to beat, right? In this point, they are. There's a term that I kind of made up. I don't know. I've never heard it, so I kind of use my own word on it. But I call it reliability, meaning if you have 100 patients with eczema presenting to you, I feel like if I give them a topical steroid, essentially 100% are going to have some improvement when I use this. I mean, barring the TSW patients, they're going to say, "Wow, that really helped." With some of the different non-steroidals, it may not be that high. For me, particularly tapinarof, which is a cool medicine. It's a great drug and has some interesting things, but in my hands, it's been pretty unreliable. Like, a lot of patients don't really care for it. It didn't seem to help. It may have even been irritating, but some love it. So that's kind of a little bit more of the art. It's like, how do I pick? I don't want you to have a bad experience. So the reliability, the accessibility is unparalleled. For $4, you can get a tub of triamcinolone, right? Yeah. And of course, we know a lot about their safety. Is it possible that we'll find out that one of the newer medicines has some weird side effect? Sure, right? I mean, we learn weird stuff all the time. So I get it. I totally agree that steroids are better from that standpoint, but we also know some of the bad sides of steroids. So I think for the appropriate patient, for somebody with mild or moderate localized atopic dermatitis, probably none of this really matters. They can do their gentle cleanser, good moisturizer, use a steroid intermittently. You're great. Good luck. You're fine. You're not really who we're talking about. So don't change for that patient. It's the patient who comes back and either says, "Hey doc, I used this and I didn't get better," or "I got better." This is the common one. "I got better, but I found as soon as I stopped, the day I took a day off of triamcinolone, it came right back. So what do I do now?" Now, I think the wrong answer is go stronger, or here's prednisone. Like, that's the wrong answer, clearly. The right answer is say, okay, let's try to make some changes. Can we give you a non-steroidal now to use to go intermittently, or can we do something different? It doesn't have to be one of those. It can be something different. And I think that's the secret, listening to the patient and really optimizing for that patient.
Yeah, I actually do the same thing. If I'm giving them topical corticosteroid, it's usually I see them back in about 4 to 6 weeks, and I ask them, how many times did you need the steroid over that time period? And that gives me an idea. Do you need a more long-term maintenance solution, or is this one of those things you used it for 3 days, it cleared things up, and then you're good to go? Because when it comes to reliability, if I know it's going to work fast, they can get it. It's less headache for me in my office, obviously. But kind of taking us back to the original conversation about the topical steroid withdrawal, let's say we have these patients, we have our non-steroidals in our toolbox, we obviously have our steroids that we don't want to use. How would you manage these patients so that you're optimizing the care that they're getting from an AD standpoint, but not potentially causing a recurrence of all of their topical corticosteroid withdrawal symptoms?
Thank you. A couple things. I just want to make sure I get those into for anybody at this point in the conversation. Thank you all for staying with us for so long. I know we're going at it here. It's great. But if you still are skeptical, I'll point out a couple things. The UK government actually now formally recognizes this, as does the Canadian government. And then for people that say there's no publications on it, there have been a whole flurry of publications on it. In fact, we wrote a big review article in the pediatric literature, a big review article in the adult literature. But then one of the papers I just want to make sure people have seen is the one where Dr. Ian Miles, Myles, he's an allergist at the National Institutes for Health. He wrote a recent paper, came out just in 2025. It's called Topical Steroid Withdrawal is a Targetable Excess of Mitochondrial NAD+. It is a very neat paper, and it's in the Journal of Investigative Dermatology. Okay, this is a pretty top tier journal. It is a deep dive into this. They did all sorts of specialized studies. They've looked at the IL-13 levels, which are really, really high. They're actually seemingly higher than atopic dermatitis. They looked at all of these different aspects. So he feels pretty confident. And I think this paper tells a very compelling story that this is a distinct entity from conventional atopic dermatitis, although it seems closely related. Again, with IL-13 being so high, it seems like it's a cousin. And then if you dig into sort of the supplements, there's all sorts of interesting stuff, including a very neat little side path on some of the treatments they tried. So let me go back to that point. So for a patient with TSW, what are my general treatment approaches? Or for somebody that has atopic dermatitis where you want to kind of get off that pathway. Honestly, it's the same thing for me, whether I think they have TSW or I'm worried that they're overusing steroids. I kind of treat it the same. The things that we have evidence for so far, and admittedly, very sparse evidence, and I've written some of these papers, they're anecdotal, some of them. But dupilumab for my patient population has shown a very reliable effect for patients with self-diagnosed TSW that I agree is TSW. It really does seem to help. It's not a cure-all. It's not going to get everybody perfect, but it really does seem to have a measurable effect. And again, this is something I would recommend for severe atopic dermatitis or moderate atopic dermatitis patients that are failing. So we'd switch to a biologic. Dupilumab has the most evidence because it's been around the longest, but my presumption would be Trelo and Lebri, same pathway, IL-13, should be great. So those would be reasonable. Recently, I've had a number of cases not yet published, but responding to nemolizumab, the IL-31. So that's another approach that we can do. Of course, the oral JAK inhibitors seem to help these patients as well. So another reasonable thing. So just kind of following the acne guidelines, the atopic dermatitis guidelines up to that point where we're going to get to the systemics, I think would be reasonable for both. A couple of things off the beaten track. I think we can use phototherapy as well for these conditions. And I have good luck with some of my TSW patients responding to phototherapy. This is narrowband UVB typically. Then traditional Chinese medicine. There are some case series of patients using herbs to help them. And I think this is important. We often are a little skeptical of this, but if you look into the literature, even in the Cochrane Review, there's a whole section on Chinese herbs for atopic dermatitis, and it may help some patients. So this is another thing that I will do, especially if patients getting frustrated with Western medicine or feeling like I'm not helping them. I'll refer them to a colleague and they can pursue some herbal medicine. And then finally, in Dr. Miles's paper that I just mentioned, they talk about two things. They talk about metformin, because in this mitochondrial pathway that's been disrupted, it turns out metformin, which we think about for diabetes, may actually help restore it. So they had some patients respond to metformin. And then they also had some patients take berberine. Berberine is a botanical supplement you can get without a prescription, which has, some people call it kind of an herbal metformin. It has a similar effect on that pathway. And they also showed an improvement there. So controversial. I was shocked that those made it through peer review to throw in some, random kind of anecdotal reports, but they were there. So check that out. And those are things I do talk to my patients about, particularly berberine, because I don't need to write a prescription. I feel like it's easier for them to get, but I will often pair that with other things. And that has been kind of interesting to see.
Well, I really love the thinking outside the box when it comes to this particular entity. And I think that, again, touches upon the heterogeneity of the inflammatory disease landscape in dermatology, because we think we have AD pinned down and IL-4, IL-13 are our key cytokines. But based on what you're telling me, we have these other pathways that are getting activated in these patients. I kind of like to call the topical steroid withdrawal patients like AD on steroids when I see them, because it looks so much worse. And with the IL-13 levels that you just mentioned, it kind of feels like that, like everything is so extreme. But if our traditional routes don't work, I like the idea of using a systemic, because again, if I give them a topical, maybe it doesn't work fast enough, maybe it doesn't cool it down quickly enough. And now with our targeted agents, we can better target that pathway as a whole. But I definitely think that it's important for us, whether our audience believes in this entity or not, these are patients who need to be treated. And so what are we going to do? They're coming to us. We got to be clinicians and treat the person that's sitting in front of us.
Amen.
And so I think we covered a lot of ground here. Just before we wrap up, any final points that you have for our listeners about AD, topicals, steroids, non-steroidal that you want them to walk away with?
It's still the hardest disease that I treat. It's still humbling every day, but it's also the most satisfying to turn somebody around when they are miserable and itchy and not sleeping and infected, and turn that around. It's like one of the most transformative things. So hang in there, stick with it. I agree it's hard. I wish I had easy answers. There are no easy answers. There's no shortcuts. But I think just listening to the patient, working with the patient, finding what makes them happy, and not giving up, right? That's a lot of what I do. I'm like, okay, let's try another crazy thing. What else do we think might help you? Because at the end of the day, by definition, as we've discussed, these are patients who kind of haven't read the textbook. I agree. They're not following the rules. That's the whole point. That's really where it becomes our job to be a specialist and to be thinking about these solutions for these patients. So I think it's kind of exciting, and I'm so grateful that we have more tools than ever before to help these folks.
I couldn't agree with you more. And I think on the topical steroid question mark and discussion that we had, it's not about avoiding our topical steroids, but it's about using the right treatment at the right time for the right patient. And that's how we really protect our patients and minimize the risk, deliver the best results. But I have to say, Peter, every time I chat with you, I learned something new. And I'm going to have to look into some of those references that you mentioned, along with those Chinese medicine recommendations, because I have a lot of people in my neck of the woods who want a more natural approach, may not be thrilled with, like you said, Western medicine's approach. So it's good to have some additional tools in our toolbox so I can see that smile in a patient that gets better. So this has been a great, powerful conversation. And I know I'm walking away energized to use these tools and bring them to my bedside. And I hope our listeners are too. Thank you again, Peter, for being here today.
Thanks, Mona. See you soon.
Stay tuned to Derm Docs, powered by LiveDerm, for more dermatology education coming to you soon.